Welcome, everyone, and thank you for joining us today for our webinar on the Canadian Women's Heart Health Alliance Atlas Chapter 7, Sex, Gender, and the Social Determinants of Health. We'd just like to run through a few housekeeping notes before we get started today. If you can please use the Q&A function to notify the presenters and moderators if you're having any technical difficulties throughout the session, or if you do have a question, please, again, type it in through the Q&A box. And to check your audio settings, if you're having any problems, you can always click test speaker and microphone right by the mute, the video button. Due to the nature of this public platform, we ask that you keep your questions general in nature. If you have a more personal question, we recommend you contact your healthcare provider.
Thank you so much and welcome everybody. We're so happy to have you here. In her book, Braiding Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants, Dr. Robin Wall-Kimmerer reflects on the meaning of land to the Indigenous people, and she writes, "In the settler's mind, land was property, real estate, capital, or natural resources, but to our people, it was everything. Our identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the source of all that sustained us. Our lands are where our responsibility to the world was enacted. It was sacred ground. It belonged to itself. It was a gift, not a commodity. So it could never be bought or sold. These are the meanings people took with them when they were forced from their ancient homelands to new places. Therefore, we would like to begin today by acknowledging the Indigenous people of all the lands that we're on. While we meet today on a virtual platform, we'd like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding of local Indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that have called this land home." Next slide, please. So we are so fortunate to be here, and we're so happy to present our Chapter 7 of the Atlas. And the people that will be involved in the presentation today include my co-host, Dr. Sharon Mulvey, who has been with us from the beginning. Well, everyone's been with us from the beginning on the Atlas, but instrumental in making this happen. Christina Stewie is our person with lived experience who's going to help support us in this presentation today. Dr. Shasheen Jaffer, who is a clinician scientist in Vancouver, British Columbia. Dr. Heather Foltz, who is also a scientist from Saskatoon, Saskatchewan. And I'm Colleen Norris, and I'm from University of Alberta in Edmonton. We would like to, you just learned who we are. By the way, we also have the incredible support of the Canadian Women's Heart Health Alliance on helping us do this today as well. So we have a polling question. So who's joining us today? So we'd like to know what you're doing and who you are at, where you are at. And so we ask you to complete the following poll. I don't know how long we give it. There we go. So 30% clinicians, allied health, persons with lived experience. Oh, welcome. That's so wonderful. Research trainees, that's wonderful. Thank you so much for all joining us today. I am going to turn it over now. Oh, do the disclosure. We don't have any affiliations, financial or otherwise, with commercial organization. These are our disclosure statement. And I'd like now to turn it over to Sharon, who's going to carry on. Thank you, Sharon.
Thank you, Colleen, for a great introduction. And it's really wonderful to be here. I can't believe we're at the 7th chapter. We have just had such a wonderful experience doing deep dives into women's cardiovascular health. And today we're going to talk about the social determinants and of health and how that intersects with sex and gender. So we'd like to review the intersectional nature of these relationships, like how they're actually interacted and combined and intertwined. And then we will touch on the sex and gender factors that influence our awareness, the challenges with access to care, and the overall health outcomes in cardiovascular health and disease, and how they are actually impacted by sex and gender and the intersection with social determinants of health. And we'd like to kind of finish up with some identifying some gaps that clearly are present and that are uniquely more impactful in women than in men, and to perhaps even address some concepts on how we could go forward with a call to action to invoke change. Next, please. So Colleen mentioned the Canadian Women's Heart Health Alliance. I think probably most of you are very familiar with this organization. It's amazing that we've been here now for 5 years, launched in 2018, and have over 200 members now who really are grassroots individuals across all walks of life, from women with lived experience through to clinicians, researchers, and allied health supporters. It's just an incredible organization, and the passion that everyone has brought has really moved forward the projects that we have undertaken. Overarching mission has been to disseminate education and best practices regarding women's cardiovascular health, and to be able to eliminate knowledge gaps, and with the hope of developing evidence bases so that we can have a guideline directed care for women in the cardiovascular space, and be able to improve outcomes. Next, please. So the way that we've organized ourselves is across project themes. We used to call these working groups, but buckets basically of where we have been able to organize and put our effort. But as you can see, these are all overlapping in a spectrum from advocacy through training and education, research, knowledge generation, which is our newest kid on the block, the knowledge translation and mobilization concept, where we really need to be able to understand where the gaps are and look at the data and how to get more data, have research focused programs, etc. And then the ultimate is to be able to interact with health systems and make change to move forward. Next, please. I'm going to turn it over to Colleen, because we worked very closely together over these last few years in our knowledge translation and mobilization working group and the health systems and policy working group to come up with this atlas of cardiovascular diseases in women. And Colleen, do you want to explain it a bit?
I'd love to. Thank you, Sharon. So in 2018, Sharon Mulvey and I, with our hats in our hands, went to our friend and colleague, Dr. Michelle Graham, who has just started as the editor of CJC Open, to pitch her on the concept of the Canadian Women's Heart Health Atlas. And this was to be used as a vehicle to provide these deeper dives into the gaps identified by the Canadian Women's Heart Health Alliance original scientific statement that we had published in CWHHA, which was the state of the science in women's cardiovascular disease, and importantly, a Canadian perspective, and was authored by members of this Canadian Women's Heart Health Alliance. Michelle was incredibly supportive, and as another can-do person, the Atlas was actually born. And this is a roadmap of the Atlas, which is organized into 9 unique chapters. Publication commenced in February of 2020, and the first 8 chapters have now been published, which is absolutely incredible to me. Chapter 9 will be published in the CJCO special edition that we have planned for Heart Health Month in February of 2024. Each chapter is accompanied by the infographics that report on the current state of the cardiovascular disease in women. And the goal is to help clinicians and women with lived experience recognize the unique aspects of women's heart health. So I have the pleasure of introducing our woman with lived experience, who's going to talk a bit today. And Christine Stewie is going to share her heart health journey. But I just wanted to mention that Christina's came to a talk and then that I did in Calgary. And afterwards, I got her to join the Canadian Women's Heart Health Alliance. And at the time, she was working with her husband on this book. And the book is available, and yes, it's my heart. Is it yours? And it's really an instrumentally great book for people to understand about a woman with lived experience journey. And I'm going to turn it over to Christina now.
Hi, everyone. Thank you, Colleen, for that wonderful introduction. That was a great meeting, by the way, where we first met. I am a woman with lived experience, as I've had open heart surgery and a triple bypass at age 47. First, I would like to thank my husband, Sven, for being there and ever present for me and my needs along this journey. Next, I would like to thank Heart and Stroke for allowing me to be one of 4 women representing them this year. It has been a huge privilege and honor to represent them and what they do. And lastly, I would like to thank the CWHHA for allowing me to share my story. How did I get here? I was sitting in my recliner on February 17th, 2017, watching cartoons with my son, who was 8 at the time, when suddenly my heart was pounding in my chest and felt like a freight train. I needed to know why it reacted like that. With hindsight being 2020, my heart journey actually started 8 years prior. While pregnant with our son, I had developed gestational diabetes and hypertension. My obstetrician had warned me about future challenges with diabetes, but nothing was mentioned about my heart possibly being affected by the challenges I had in pregnancy. In fact, gestational diabetes, hypertension, or preeclampsia doubles a woman's lifetime risk for heart disease. And that's from the Misunderstood brochure, page 9, Heart and Stroke, 2018. So back to me. So after 3 abnormal ECGs, several blood tests, 1 24-hour heart monitor, and 7 months, I met with a cardiologist. The next step was to do a stress test and an echocardiogram. The latter is what finally gave us a glimpse into what my heart was dealing with. It identified that my lower left ventricle was functioning at 35% instead of the normal 55%. Having all this information in his hands, my cardiologist wanted to wait a year and see what would occur. My husband and I looked at each other. We knew now that my heart was struggling and needed help, yet I was being brushed off. We would not be leaving his office until we had a more conclusive test booked. So on November 16, 2017, I had an angiogram done. The results were overwhelming. One artery was 100% blocked, which meant I'd had a heart attack approximately 3 years prior. So at age 44, 6 years after the birth of our son. I had 2 other blocked arteries, one at 70%, the other at 80%, and then 90% the further it went up. I was told that day that I needed a triple bypass to be performed by open heart surgery. So as luck would have it, I met my cardiac surgeon for the first time on Valentine's Day, 2018. Dr. Teresa Kieser was the only female cardiac surgeon in Alberta at the time, and I was blessed to be assigned to her. I had concerns about the chest scar that I would have to live with. Dr. Kieser listened as I spoke about a scar starting at the sternum would very much limit my choices of tops in general. She not only listened, but she acted on my female-specific concern and purposely made my incision 2.5 inches lower because I had expressed my fear. The majority of doctors don't even consider this to be an important factor. I had been told by only one nurse in the 4.5 months waiting for my surgery that I should look at getting a bra that opened in the front but clasped in the back, so as not to disturb my incision as it was healing, but still have some frontal support. If it weren't for this one nurse telling me, I would have been very uncomfortable and in pain more so if I hadn't gotten a proper bra for recovery. After surgery, while recovering in the cardiac ward, my husband and I noticed that I was only one of 3 women in the entire ward, which is odd considering heart disease and stroke are the main causes of premature death in Canadian women. That translates to every 16 minutes, a woman in Canada is dying from heart disease or stroke. Again, that's from the Misunderstood brochure, Heart and Stroke, 2018. Once I recovered enough to do cardiac rehab, my husband and I once again observed that there were hardly any women in attendance. Cardiac rehab to me was so important as it gave me confidence to work with my improved heart as well as to learn and to adjust to my new limitations. I needed a group environment to heal in and receive attention for my fears and questions. As women, I know we put ourselves last in the scheme of things, but in order to take care of others, we must take care of ourselves. This must be encouraged in our current healthcare system so that we as women can give ourselves permission to not only be ill, but to have the resources and help required to heal and get better. On that note, I wrote and self-published a book this year, about my heart journey and what I learned along the way. I wrote Yes, It's Your Heart, Is It Yours Too? For that exact reason, to help other women navigate their heart journeys, especially in regards to their hearts or their health journeys, sorry. We need to be able to not only advocate for our health, but have a system that supports us to heal from our health challenges. Thank you so much.
Thank you so much, Christina. It's such a moving story, and I appreciate everything you've done for us and women's heart health in Canada. Thank you. I started my video. So I am going to introduce Chapter 7, and it's the Canadian Women's Heart Health Alliance, and we're looking specifically at sex and gender and the social determinants of health. I wonder if we could go to the next slide, please. I want to be specific here in these discussions. It's important to understand the distinction between sex and gender. And sex is biological chromosomes at birth, so female or male at this point. And it encompasses hormones, genes, anatomy, and physiology. And all of those affect our health and our health outcomes, but we actually haven't been paying attention to any of those as far as women's health is concerned. And we are now being able to pay attention by forms like this. Gender, on the other hand, is it's a social construct and it's culturally specific, but it isn't just gender identity and how you present yourself. That's one of the factors. It's incredibly important, and it has been shown to have an association with health outcomes, but it's also your gender relations and the social constructs and institutionalized gender. Next slide, please. So women and their healthcare providers are still under-aware of the CV risk factors and symptoms, especially in the younger women that are presenting. And younger, we're talking anywhere, from 35 to 55, those in minority or low socioeconomic status. And so we're going to talk about some of those and the associations of those variables or the social determinants of health with CV outcomes. Next slide, please. As excess burden of CVD and associated risk factors in racial and ethnic minorities highlights the need we have to focus on improving culturally and sensitive clinical cardiovascular care and research. And there is unavailability of universal access to sex and gender specific healthcare results. And that includes a paucity of clinical trial data. So the work that we've done demonstrates that, even when women are included in trials, it's like 30% of the women. And then what we end up doing as researchers is we combine the data between the men and women and then say that this treatment or whatever we're looking at as far as the clinical trial data is concerned, is right for women. And we actually don't know that. And there's really a lack of national health policy addressing any of these basic issues of the differences of sex and gender and the social determinants of health. Next slide, please. So sex influences gender-specific experience, which intersect with all of these social determinants of health and cardiovascular risks in females or women. And the manifestations of that or how it shows up. Dr. Jaffer will now delve further into these social determinants of health. So I turn it over to you, Dr. Jaffer.
Thanks, Dr. Norris. So, there are significant disparities in cardiovascular disease burden amongst women, particularly those who are socially disadvantaged due to income, education, race and ethnicity. And I'm going to focus on the latter two over the next few minutes. First, I'd like to present Maya. She's a 55-year-old South Asian woman who works as an accountant, and she's been having intermittent chest burning, which has really become worse during, the busy tax season when she's working 13, 14 hours with her clients. She has a history of prediabetes, high cholesterol. She's on atorvastatin, and she's had depression for about a year. She does have a family history of premature heart disease. Her father had a myocardial infarction at age 49. So she saw her primary caregiver and she was diagnosed with gastroesophageal reflux disease and was put on a proton pump inhibitor, but she had minimal relief with that. One day, whilst busy at work, she had severe chest burning going up into her throat, and she almost passed out. Of course, 911 was called, and in the emergency department, she was found to be having an acute inferior MI and heart block. In the CCU, a temporary pacemaker was implanted, and she underwent emergency cardiac cath, which showed 90% stenosis of her right coronary artery, which was then stented. And aggressive risk factor management was recommended. So, think about these questions that I've listed here. What were her symptoms that suggested possible heart disease? And what were her risk factors? And why were they not addressed? So just quickly, women present just as often as men when they have heart disease with chest pain, but women tend to describe their chest pain a little more differently, like chest tightness or chest pressure or even chest burning. And her risk factors, well, she's South Asian. Hopefully by the end of this session, you'll be convinced that's a significant risk factor. So she's South Asian. She's got high cholesterol. She's got, mental health challenges. She has depression, which is one of the under-recognized risk factors for heart disease in women. And she's got a family history of premature heart disease, and that's 4. And then, in my books, although she's not diabetic, prediabetes is a risk factor, so I give it half a point. So she's got 4.5 risk factors. And why were they not addressed? Well, there could be, a number of reasons, but I think the biggest thing that we all are realizing and now know is that there's a huge gap in the healthcare professionals as well as in the general public about women's heart disease overall. Next slide, please. So now I'd like to just share some information on racialized groups in Canada. The 2021 census data on race and ethnicity indicated that the total racialized population in Canada comprised close to 10 million people, which is 26.5% of the overall population. And this has increased by 4% since 2016, when it was 22.3% of the Canadian population was racialized. The largest ethnic group, as you can see here on this graph, is those of South Asian origin, comprising 7.1% of all ethnicities, followed by Chinese 4.7%, and Black populations 4.3%, and other groups, as you can see in this chart. And each racialized group comprises approximately 50% women. Next slide, please. So South Asians and Blacks are at increased risk for atherosclerotic cardiovascular disease, hypertension, and stroke when compared to Caucasians. And type 2 diabetes is also more prevalent. South Asian women in particular are at 3 times more likely risk to develop diabetes in pregnancy. To add to this burden, heart attack and stroke can occur much earlier, 5 to 10 years earlier compared to other ethnicities. And these risk factors portend a much higher hospitalization and mortality rate. East Asians have the lowest incidence of cardiovascular disease. However, one study from Ontario did show increased heart failure. And the greater their duration of stay in Canada, the greater the East Asian, cardiovascular risk becomes. Also, lastly, people of Black and Asian race are also at higher risk for non-obstructive coronary artery disease, which many of you may know as MINOCA or MI or ischemia with non-obstructive coronary arteries. Next slide, please. So this slide demonstrates that when we combine a larger number of outcomes, not only heart attack or stroke and death from these causes, but also procedures such as percutaneous coronary intervention, such as what Maya had, the stent procedure, or coronary artery bypass grafting surgery, South Asian women, and I've put red asterisks beside these 2 points, South Asian women and men have the greatest number of cardiovascular events, surpassing not only ethnic minorities, but also the Canadian population that has lived in Canada for decades. So South Asians have an extremely high burden of cardiovascular disease. So that brings me to the end of this portion on race and ethnicity, and I'd like to pass on now the torch to Dr. Folds.
I'm going to continue talking about social determinants of health and building on racialized women to look at Indigenous women's experiences in Canada. So I have a case to kind of highlight a few of the social determinants of health that Indigenous women might face, and there's some questions for you to ponder as we're thinking about this and moving through the slides. So Maggie has previously suffered a heart attack and a bypass. She's returned to her home community about 6 months ago. So she gets up in the morning and she phones the clinic as soon as they open, trying to get an appointment. She does manage to get an appointment for that day. So this can be quite common in some communities, that you can't plan your doctor's appointments in advance. You have to try and get them the day of. So when she goes in, there's a locum attending that day, and once again, it's a new face that she hasn't seen before. There's a lot of turnover or different people coming in from day to day, so that continuity of care can be a challenge. So in this case, Maggie speaks Dene as her primary language, and she sometimes struggles with English. So there's a brief time that she's available to see the doctor, and in those few minutes, she's trying to communicate about chest pain she's having when she experiences walking up the stairs. The locum seems to understand that her chest pain is from colder air of the changing seasons, and recommends an inhaler. So those language barriers can be quite impactful as well. Next slide. So some of the differences that Indigenous women face that other Canadian women won't face, some of those jurisdictional challenges between the NIHB or federal responsibility for health compared to provincial. Some of the things that are covered under healthcare might be a little bit different, and that can have some impact in how you're seeking healthcare. What kind of coverage you have available and where, and how far you have to get to find a hospital or primary care center or urgent care centers. Of course, there's been lots of publications and discussions around discrimination and racism in healthcare that Indigenous people are facing, but also thinking about microaggressions and stereotyping, and not just stereotyping about what it might be that people are trying to seek help for, but also stereotyping what type of care they have access to. So whether they have other types of medical coverage through work, etc., that might be able to further benefit their support. As I highlighted, those language differences, and then thinking about cultural differences. So things like the way people physically show pain might be different between different cultures. So you might not be seeing pain that you recognize, but they might be showing it in the ways that they are used to, for example. And then cultural connectedness. So some of my work has shown that being connected to your culture is associated with reduced hypertension. So there's some benefits of being connected in there, and knowing that many individuals might be seeking a combination of wellness strategies, with it combining traditional medicines or traditional practices with Western medicine. And then, of course, colonization and family structure are considerations, and thinking about the different roles and responsibilities, a different gender structure that might be positioning Indigenous women with different challenges. Next slide. So moving beyond Indigenous women to look at different environments. So starting with an example of somebody living in a northern rural community. So in this case, Lee is pregnant and has some signs of preeclampsia and gestational hypertension. There's a nursing station about 20 minutes from her community, but the nearest hospital and obstetrics facility are about 3 or 4 hours drive away. In her local community, the water source is contaminated, so it's not just a boil water advisory, but you can't drink the water there. So the food sources that she has available, there's a small convenience store in her community. They have things like pops and chips and hot dogs and those types of foods, but the nearest grocery store is a couple of hours drive away. So again, some of those questions to think about how her lifestyle is influenced by influencing her risk of heart disease, and how this might be different because of where she's living. So what can we do to help with these inequalities? Next slide. So if you can imagine, the map on the right is from Alberta, showing the locations of different places. So if Lee is from a community, for example, up in the top of the slide, top of the map, then we're looking at 3 or 4 hours away to the nearest emergency ward, obstetrics a little bit further away. So some people in different communities don't have the same access to those types of of healthcare as easily as others. So I talked about potentially, driving a couple of hours to get to a grocery store. And when you get to the grocery store, you can see these kind of prices. So watermelon for $63. Would you be buying a watermelon or fresh fruits if this is kind of the pricing that you're facing when you get to those grocery stores? So some more food for thought and challenges that different women in different places face. Just commenting that they face different challenges. So having to get to different places, and then so there's resources and costs of traveling those hours to get to grocery stores. And then when you get there, things are more expensive. And because of things like challenges in access to clean water or other types of things, that it can make it more, layers and layers of challenges depending where you're living. Being in kinesiology, thinking about physical activity. So in rural communities, things like, going for a walk in the neighborhood, which is often an easy, cheap solution that we think of, is not necessarily a safe option in all communities. So when we look at urban communities and low-income neighborhoods, women in these neighborhoods also face increased challenges for their heart disease. And even after we adjust for their income differences, women in these low-income neighborhoods are also facing greater heart disease. So there's something about these neighborhoods that makes it not as supportive of their health. So it might be things like air pollution, and we report in the chapter that women are more reactive to air pollution compared to men, so it might have a greater impact on their heart disease. But also thinking about the safety, cohesion, aesthetic neighborhood, so that built environment, is it easy to get to places? Can you walk there? Can you take the bus? Or do you have to cross the highway or the train tracks to get to the park that's 2 blocks away? Is it a safe neighborhood for you to walk? Is it a place where you feel comfortable or appealing? And then those food deserts, I think deserts, thinking about not dessert, though, the lack of grocery store access, because there's just not one in your neighborhood that you can get to. And if you're living in a low income neighborhood, you might not have a car. So then how many transfers on the bus do you have to take to get to the grocery store? Next slide. All right, I have one more case for you to think about, and we're continuing to talk about different risk factors that women might experience that are more common, and those sociocultural factors, so how different women in different cultures might have different experiences. So in this case, Manpreet is having anxiety. She has 3 children, as well as elderly parents to care for. Both her and her partner are working full-time. However, Manpreet is solely responsible for the cooking, cleaning, and childcare in her home. So thinking about what kinds of risk factors for heart disease is she experiencing, and are there things that we can do to address this situation? Next slide. So some of the social cultural factors that increase risks for women, those rigid gender roles. So often we think of women being emotionally responsible for the household, carrying all of the emotional labor of organizing and planning and childcare and so forth. If we add in things like marital discord, domestic violence, this can increase women's risk of heart disease. When they're facing challenges in getting healthcare because of language barriers, discrimination, and so forth, cultural differences in understanding gender roles or cultural differences in gender roles. These can all change women's experiences and increase the risks for some women, as well as a lack of time and diversity among clinicians in accessing healthcare can influence their experiences. So we need to think about some targeted, linguistically tailored, culturally specific, and sensitive health education, preventive care, and treatment options. And next slide. So thinking about approachability when women are engaging in healthcare, acceptability, so accepting the different circumstances, different conditions, also accepting that heart disease is a women's disease and that women's experience of heart disease is different than that of men. So having availability, being able to access healthcare accommodations for whatever the circumstances we need, whether that's language or culture or so forth, and then having appropriate care for everyone. So when we're thinking about this approach of making safe, accessible, appropriate care and prevention of heart disease, we immediately think of healthcare settings and making sure that our healthcare settings and clinicians are safe and appropriate. But this also applies to research and clinical trials. So making sure that clinical trials are including diverse women of diverse perspectives and including those different locations and experiences. and also talking about training and education. So training and educating our healthcare professionals to provide care, whether that's targeted training, whether you're in certain communities, or training that's more broad for a larger center. Also educating the public, so things like Wear Red Canada, and trying to get out the message that heart disease is a women's disease. And I think that I am going to pass it back to Shaheen now. Thank you.
Okay, thanks so much, Dr. Foles. I'd like now to talk about intersectionality. So this is a term developed by Black feminist legal scholar Kimberly Crenshaw. It's a framework, or as she says, a lens, through which we can see where power comes from and where it collides. It's not simply that there's a race problem here, a gender problem here, and a class problem there. It is, in fact, as Dr. Foles and I have spoken about, the overlap or interconnectedness of all these identities. And you can see the wheel here that we've developed. It's not a very broad wheel, but it's specific to Chapter 7, and you can look online and find many other wheels that are more complex. So these identities of advantage and disadvantage, they all impact one's experience in society. And there's evidence now that these identities are also under-recognized cardiovascular risk factors or forces above the skin. And also, it's not only the individual risk factors, but system factors like colonialism, racism, patriarchy, capitalism, and other isms that also significantly impact power and privilege or lack thereof. And these under-recognized risk factors increase women's cardiovascular morbidity and mortality. And I hope that the cases we've presented today exemplify this framework of intersectionality. Next slide, please. So this is a study which demonstrates this concept of intersectionality in racialized and Indigenous people. You can see that increasing social disadvantage, so going on the x-axis from left to right, worsening of your score, was independently associated with cardiovascular burden, which is on the y-axis here. So Indigenous people and South Asians, male and female, were with both ethnicity and sex characteristics that were more socially disadvantaged, i.e. they were unemployed or had lower income, lower education, or single, socially isolated, or lived remotely. They had the highest probability of cardiovascular disease when compared to European and Chinese male and females of the same social disadvantage. So again, more data to support the important contribution of under-recognized risk factors in women's heart health. And I'll pass on to you now, Dr. Norris. Oh, sorry, I'm sorry, Dr. Mulvey.
That's great. No, I want to thank both you, Dr. Jaffer and Dr. Foles, for excellent presentations and a really impactful presentation from Christina Stewie. We really appreciated that. It does personalize the whole situation. And I hope that you all will get a chance, or perhaps have already had a chance, to look at our Chapter 7, where we do go into each of these areas that have been covered today, specifically about the challenges as it affects women and females, gender and sex, in the interacting with the cardiovascular disease, awareness, perception, access and delivery of care, environmental influences, and of course the ethnicity, race-based factors, and sociocultural factors. We must be very mindful of, particularly as healthcare providers, of the patient that's sitting in front of us, and to be able to meet them where they're at, and to provide a culturally sensitive and comfortable and appropriate care. This is not that easy, because we might not all be that experienced in doing that, but it is extremely important, and particularly for, I think, our women patients, because of their increased sensitivities. Next, please. I think that both I'm going to say Shaheen and Heather, because we're all friends here today, really brought out the importance of the increased cardiovascular risk in our Indigenous and racialized women, and how that they are at a significant disadvantage when it comes to these social determinants of health. It's really, as Shaheen outlined very nicely at the end, it's got a lot to do with the power imbalance that exists. Our systems are not made to hear voices of people that are in minorities, and we need to be their advocates. Of course, as much as possible, individuals need to advocate for themselves, but sometimes that can be very difficult, and we need to provide the proper support. I think that when we explore this, there were a lot of questions asked. The cases were very poignant and brought out a lot of great points. But we don't really have all the answers to those questions. But we do have an opportunity to address the issues and develop action items. And that's what we are trying to do with these webinars, actually, is to increase awareness and to have a call to action. And in this situation, I think we would all agree that we need to develop contextually and culturally relevant clinical and education programs. We need to be able to enhance the opportunities for our marginalized women to have access to care, and when they do get into having care, to be able to have that care delivered appropriately and in a sensitive way. It's not easy. And it takes system change and policy change. But if we're at least aware of it, then we can make some individual as well as broader changes to be able to reduce disparities. With respect to clinical tools, when we talk about clinical tools, we're thinking about risk factor assessment scoring systems that we use. We put in different factors, age, sex, and risk factors that are traditional risk factors. But women are disadvantaged because, as was well outlined in one of the cases that Heather showed, in our scoring systems, we don't have the opportunity to include a history of adverse pregnancy outcomes or hypertensive pregnancy disorders such as preeclampsia, gestational diabetes, etc. And we have to think of these as risk enhancers, and actually they have been documented as such in the guidelines that have been published south of the border. Even though not included in the basic risk scoring systems, it is recognized at least that sex unique and sex more common or sex predominant factors are risk enhancers that particularly affect females and or women. So being aware of these tools and utilizing them or modifying them with respect to your clinical acumen is very important as a healthcare provider who cares for women with lived experience. And as the woman with lived experience, to be aware of these unique aspects of risk factors and to ask questions about it. Sometimes it's up to us as the patients to educate our healthcare providers. We are working very hard by trying to disseminate all of this information and to be able to provide educational and training opportunities for our colleagues. But sometimes, it works well from the bottom up as well. And then, of course, research. It's essential that we have to mandate inclusivity in research. And this particularly, I think we're doing a good job with respect to the mandates that have been put out by our Canadian Institute of Health Research requirements, as well as the Heart and Stroke Foundation, for having a plan in proposals that are submitted to analyze by on the basis of sex and gender, or if it's not included, then it has to be justified as to why not. But we also need to have plans that address racialized individuals or the aspect of racial identity, as well as ethnic identities, and particularly for our Indigenous people. Our Indigenous women are far more at risk than any other group, probably very closely followed by our African, Canadian, and South Asian women. All have far more risk for cardiovascular disease. We don't understand all of the reasons, and maybe we can ask Dr. Jaffer and Dr. Foltz to explain their thoughts on this in the question and answer session. But we need information. And if we don't analyze data based on these characteristics, then we're not going to get that information. So I think that's a thoughtful chapter. We don't have all the answers, but I think we raise a lot of observations and a lot of questions and a lot of potential for moving forward. What about this? I'm going to ask Dr. Jaffer first to kick things off. What about this thin fat syndrome that we see, particularly in South Asians? Why are they at more risk metabolically, and particularly women? Can you give us a little bit of an insight on that, Shaheen?
Sure, great question, actually. So, metabolic abnormalities, as you all know, are quite prevalent in South Asians. And we know that even at lower body mass index or lower waist hip ratio or waist circumference, women of South Asian origin get heart disease, even at lower BMIs. Now, there's something called, so they're a high risk phenotype, and there's something called the thin fat syndrome, where it's known, genetically that South Asians have larger sized fat cells and they have greater fat distribution, in their livers. And this is thought maybe to account for the higher cardiovascular risk. So in response to that, and thank you to the Alliance for pulling up this table, and this is in chapter 7. And what you'll find is that, many international organizations, so, the International Diabetes Federation and the World Health Organization, they've actually proposed, and many places like in the UK, they're actually using these cut points. So, in a Caucasian person, if you just scroll down a little bit there for me, thank you. So a little bit lower to the obesity section. So let's just focus on obesity a little bit higher. Now thanks. So most of you know, so just a touch higher, all of you know that the Caucasian population, looking at BMI for obesity, the cutoff point is 30. Whereas what's been recommended in, let's just say, South Asian people, the cutoff is actually been recommended, proposed to be more than 24 as the definition of obesity. And, BMI doesn't work well in everybody. So we're now looking at waist circumference, which is on the far right of this figure, where in looking down, I think it's cut off a little bit, but in Caucasian women, the cutoff point for waist circumference to be obese in women is more than 35 inches or 88 centimeters. But what's recommended in South Asian people is in fact lower. It's recommended that 77 centimeters in women be the cutoff, or 30 inches. So that's where these new guidelines are coming from. And I hope I was able to answer that question.
Oh, thank you. I think that's very important. And I know there's a lot of work being done in trying to understand why is this, perhaps the body fat distribution is different, and it's different in this ethnic and potentially a genetic basis. So a lot of work to be done, a lot of research, but certainly we can't, it just goes to show you can't apply all the same rules across the board, can you? It has to have understanding beyond that. Christina, there is a wonderful compliment to you in the question box. Are you there? Good, thank you. Congratulations on writing your book. First of all, thank you again for sharing your insights. I mean, that's, it just shocked, my heart kind of sank when I heard that with a significantly reduced heart function that you were going to be just a wait and see for a year and see what happens. It was like, whoa, in a 40-some-year-old woman, that's pretty impressive. So you advocated for yourself immediately at that point, and that really changed your whole trajectory. So that is a huge lesson in itself, but you knew to advocate as well, which is great. Could you share with us a few insights about having was it a little stressful to write a book? Tell us how you accomplished that.
Well, it actually took me about 10 months, and I had made notes along the way, because I had a feeling from not seeing a lot of women in the heart recovery ward, not seeing a lot of women in cardiac rehab, that there was a voice in me that said, you know what, you need to take notes on this so that eventually you can share it. And I was just, I knew I had to share my story, because I really want women to know they're not alone. And, the slides that say, Heather went through, they were very impactful. I mean, I live in Calgary, and I'm 10 minutes away from a hospital, and I have all these blessings around me, and yet I still had challenges to go through. So I can't imagine what women have to deal with that don't have access to that on top of what they're dealing with, right? It's like we need to get the word out, and that's why I took the notes along the way, so that I could share my journey, and that women could take this book with them in whatever kind of appointment they're dealing with, but especially heart, and say, okay, well, what about this, or what about this test, or what about this? Because I had to educate myself, and I had a lot of help from the Heart and Stroke Foundation. They really helped me see and be able to create questions to ask, because I didn't even know where to start. And I think a lot of especially women deal with that. I mean, where do you start, right? And do you have classic symptoms? I did not. I had I had angina for 2.5 years and didn't know it. So, like, how many other women across the country and in the world that deal with this? And that's why I wrote my book.
So not only was it very educational, but it sounds like for you as well, it was very therapeutic.
Very
and
healing,
it was
yes.
very healing. And I think it's very key what you said about women have to give themselves the permission to be ill, but also the permission to heal. And there are unique aspects about that healing, as you described too, like just as simply as being concerned about your surgical scar, about but it's not simple, it's going to be with you for the rest of your life.
Yeah.
And yeah, and aspects of clothing, and how to get a bra that works properly, and cardiac rehab, having the opportunity, first of all, to be referred. Unfortunately, not all women get referred, and then making it work so that you can actually attend. I'd like to ask Heather for a second, and then I'm going to turn over to Colleen, because I know she's got a bunch of questions too. But Heather, it is very challenging for women who are in underserviced environments. And do you have any tips for like what can they do, and what can the systems do around them? So it's like a multi-pronged approach, but you've thought about this for a long time. You're an academician in this area. But what would you say are our best chances going forward to resolve these issues?
I think that obviously it's going to take several different initiatives and different solutions for different communities. Some of the communities in northern Saskatchewan have been working with remote technologies, so you can connect with clinicians in the city while you're not there. Some of the clinics that are going maybe a little bit better have like local people in the community working there, then they have some of that cultural support, language support, a friendly, familiar face that they can see, especially if you have different physicians all the time. Yeah, I think there's lots of work to do, and lots of different thinking outside the box needed.
Absolutely. And I think the work that you've done to identify the issues is seminal in being able to move that forward. And also, I want to congratulate you on obviously balancing many things right now as we see popping in and out your little one. So congratulations, and thanks again for your excellent presentations. Colleen, I'm looking for more questions in the question and answer box, and I know you have a couple here, so I'm going to turn it over to you.
I don't know about questions, but comments. A couple of things that it's one of the things that if you look at the bias literature, when I'm thinking about clinicians actually not recognizing that this is a woman standing in front of you that needs some investigation as far as their heart is concerned, and in the bias. When you take the bias questions that you can go on their Harvard website and look at whether you have biases to things, they're really enlightening. But one of the things it did for me was that it made me recognize that that's a bias. And it was a shock to me on the tests I took, I thought, no, I'm not biased against that, whatever. But now every time I see someone that has that determinant, I say, Colleen, stop right away, because you're thinking that this person has put themselves in this place, and that's not the case. You know, no one wants to be in the place that they're in. So it forces you, like when you start recognizing your biases, to do that. And I think that's what we need to do with clinicians, with women, instead of looking at the woman and saying, older women postmenopausal is probably this, or between 35 and 55, probably perimenopausal, probably anxiety induced because of their lifestyles. And they've already taken that tunnel rather than saying, check your biases. You don't know about this woman's life, and start thinking about it that way. And the other thing that I wanted to mention that was really shocking to me, but it's still happening, is that in one of our first focus groups, so we just asked women, what was it like to be told you had had a heart event or you had heart disease? And the biggest shock to me was they didn't want to tell anyone because it was their own fault, because society is saying you should have taken care of yourself. And even if you look like Christina and you're fit and having a young child, what are you doing wrong? Like what didn't you do right that you're in this condition? And so I think we have to get over the thinking that heart disease is a men's disease, and women have not done something wrong, especially the women that we're seeing now that are fit and they don't have the risk factors, etc. So, and maybe Christina, you want to comment on that too.
Absolutely. You know what? I didn't have any of the risk factors. My dad was a heart patient and had open heart surgery 25 years prior. So I was very diligent about getting blood tests every couple of years to check my cholesterol levels. Everything was always in the norm. So for me, the challenges started with the issues in pregnancy. And, you know, it was interesting because all along my heart journey, you know, because I had open heart surgery at 47. So I was having all these tests done, and, you know, everybody was saying to me, you're too young to have heart issues. I'm like, yes, I'm right in there with you. Like, I don't want to have them either. And, you know, that was part of writing the book for me, was opening up about that, because like you were saying, we think it's our fault. And I did go through a time where I blamed myself, and I really had to get help with that perspective, that, you know, no, there are issues here that were unknown, or, you know, we weren't aware of at the time. And I have to let myself be off the hook, but take responsibility from here forward. What can I do? You know, can I do exercise? Can I eat better? Can I make better choices so that, you know, the surgery that was done for me can last the rest of my life, right? So you do go through that embarrassment, and it's a hard pill to swallow. And you know what? On that note, we as women need help to get through just that hump, not anything else, but that, so we can change here and be able to adjust to what's been thrown at us.
Absolutely. And I think that is a wonderful message to leave, Christina. And the other half of that is really about the built environment that we are in too. And not all of us have the same built environment, as you brought that point out very, very well too. So that it is extremely important that our health systems and change, that they adapt, that we have policies implemented. And I want to just thank all of our panelists today for their excellent presentations, for their thoughtful and insightful comments. And clearly there's a lot of work yet to be done, but at least it's out in the open. Just like Christina's comfortable now speaking about her heart disease, we are speaking about the problems, and the only way that you can make change is to bring awareness to these issues. So thank you very much to Drs. Jaffer and Folds and Christina, and my ever-present wonderful co-moderator, Dr. Norris. It's just been a wonderful session, and I thank you all for taking the time out of your day to attend with us and to think about these things. And you can get all of the resources as our wonderful support team at the Canadian Women's Heart Health Alliance has been posting for you in the Q&A sections there at the Canadian Women's Heart Health Alliance website. And please do fill out your evaluations. We do try to focus what we go forward with and present to you and respond to your needs. And there is just so much information on that website. It's just a gem. And please go and explore there if you haven't before. And of course, I'll get ready for February 13th, 2024, which is going to be our National Wear Red Canada Day again, where we really, it's the pinnacle of all that we work for in our advocacy measures to improve awareness of cardiovascular disease in women in the intention of improving outcomes. So thank you for joining us, and have a wonderful rest of your day. Take care.
Everyone, thank you.
Bye.